Hello friends, welcome to AIIMS question discussion lecture number 8. Question number 1. We have a girl child who complained of involuntary movement suggesting of chorea, and she is a case of supposed to be a case of acute rheumatic fever. At present she has no complaint of carditis or arthritis. Now which of the following tests will suggest that she is suffering from some recent streptococcal infection? The answer is A, that is ASO titer. Okay. Well, let's talk something about chorea. First point, chorea is a late feature. Now there are two features in rheumatic fever which are late. One is chorea, the other is nodules. Okay. Now in fact chorea may appear at a time when all the other features have disappeared. That means carditis, arthritis, erythema marginatum all have disappeared. Culture is usually by the time patient manifests acute rheumatic fever, culture is usually negative. So this is out. Throat culture. Blood culture is never an investigation choice in acute rheumatic fever. Even PSR for M protein is not a routine investigation to be done in case of acute rheumatic fever. The only finding which may be positive when the patient has chorea is ASO titer. Okay. Now one more thing, chorea is more common in young ladies, like in our case she is a lady, young girl child, and she has an involuntary movement, and typically what we talk about is milkmaid sign. Milkmaid sign. Right. And extra feature about rheumatic fever, most common is arthritis, polyarthritis. Second most common is carditis. Now which is the most rare? Erythema marginatum is the most rare. What is special thing about polyarthritis? It usually involves large joint, and it's a type of migratory arthritis. And very important, it's a type of non-erosive. Arthritis. That means there is no deformity or dissection of the joint. As far as carditis is concerned, this is pancarditis. That means there is endocarditis, myocarditis, and pericarditis. Erythema marginatum is usually on the trunk. Okay. So they are the major criteria. As far as minor criteria is concerned, fever and arthralgia are the minor criteria. Okay. And it has to be supported by some streptococcal infection like ASO titer. Question number 2. A 30-year-old man complains of weakness, nausea, vomiting, tall T wave, that prolonged PR and absent P wave. This shows that patient is suffering from acute severe hyperkalemia. So what is not given in the management? Answer is soda bicarb. Okay, I am sure many of you have gone for the answer as calcium gluconate, but answer is sodium bicarbonate. So first of all we see what are the ECG findings for a case of acute hyperkalemia. So this is a normal recording. The first finding is tall T wave. This is the T wave. T wave has become very, very tall. Then if more hyperkalemia occurs, PR interval become prolonged. Look, this is the PR interval. It has prolonged. Later on the P disappear. so-called atrial arrest, and finally wide QRS, so-called sine wave. Okay. Now let us see what are the things we use in the treatment of severe hyperkalemia. Number one, first thing to be given is always to write down treatment of acute hyperkalemia. First is injection calcium gluconate, second is insulin, third is beta 2 agonist. These three drugs we use in the treatment of acute hyperkalemia. Now what is the role of calcium gluconate? It stabilizes cardiac membrane, so it prevents arrhythmias. Point to be noted, it does not reduce serum potassium level. Now to reduce serum potassium level, we use insulin dextrose injection. It is the fastest, best and most easy way to reduce serum potassium level. We can also use beta 2 agonists like albuterol to reduce serum potassium level. But what about soda bicarb? Soda bicarb has no role in the treatment of acute hyperkalemia. Soda bicarb we use only when there is severe metabolic acidosis. If the pH is below 7, then only we try to use, but that also we use soda bicarb to correct acidosis, but not to treat a case of hyperkalemia. But still some of you may have some doubts. Okay, so now let me tell you where the answer is given. Okay, that let's read Harrison 19th edition, page number 312. The page is like this, and in Harrison we have two columns. So in this page, on the left column, if you go from bottom, from the lower side, you go for second paragraph. In the first line, it is written that soda bicarb has no role in the treatment of hyperkalemia. I think it should give you a now confirmatory and with the answer with the confidence that soda bicarb is not a treatment of choice for acute hyperkalemia. It is a typing error. It is soda bicarb. It is B, not A. Okay, so soda bicarb is not. It's a typing error. High calcium intake can lead to milk alkali syndrome. Now let's see what are the causes of hypercalcemia. It can occur in endocrine condition like hyperparathyroid. This is known to all of you. But other endocrine condition where we can have hypercalcemia is hyperthyroid, Addison's disease. Now it can occur in certain poisoning like vitamin A, vitamin D and aluminum intoxication. It can be caused by certain drugs like lithium thiazide. It can be caused by certain cancers like hepatoma, squamous cell lung cancer, then renal cell carcinoma, breast cancer. Fifth, it can occur in sarcoidosis. In fact, sarcoidosis is a granulomatous disease. Rather, hypercalcemia or hypervitaminosis D occurs in all granulomerular disease because granulomerular tissue itself can synthesize vitamin D, which lead to increased calcium absorption from GIT, which can lead to hypercalcemia. And prolonged immobilization can also lead to hypercalcemia. Well, what is the treatment of acute hypercalcemia? Answer is you give hydration, you give saline, and after that you give furosemide. Point to be noted, furosemide is a treatment of hypercalcemia and thiazide, they are the cause of hypercalcemia. The reason being calcium is reabsorbed by the thiazide in the tubule, but calcium is lost by furosemide. That is why we use furosemide in the treatment of hypercalcemia. Question number 4. Which of the following drug is not effective against hepatitis B? The answer is zidovudine. We use interferon alpha, we use talbuvudine, we use lamivudine, we also use tenofovir, we use emtricitabine, in fact this is one drug which can be used in HIV also. Okay. Then we have entecavir, all these are the drugs that we use in the treatment of hepatitis B. Now I like to talk some extra point. Interferon alpha we use in the treatment of both hepatitis B and C, but the latest thing is in which condition we use interferon beta. The answer to this question is we use in the treatment of multiple sclerosis. In fact, this is a recent question, prospective new question. As of now of today, interferon beta is the only where we are using is in the treatment of multiple sclerosis. Is a prospective new question, and in fact it is one of the best drugs to be used in the treatment for prevention of multiple sclerosis. Question number 5. Which of the following is diagnostic of acute hepatitis B? The answer of this question is, I think before I discuss this question, let us learn the basic serology, without which you will never understand this question. So serology of hepatitis go like this. Here is the time in months: 1, 2, 3, 4, 5, 6. This is the time in months, and this is a period of jaundice. This is jaundice period, J jaundice. So you know very well that hepatitis B has a long incubation period from 2 to 4 months. So here I have shown 3 months. So during the incubation period only, surface antigens start rising, and it peaks during the time of jaundice, and by the time jaundice disappear, it also disappear usually. Soon start rising E antigen, green color is E antigen, but it tend to disappear with the disappearance of jaundice. When jaundice is going, that time IgM core antibody appear, which is the definite sign of acute infection. then come the E antibody, and surface antibody usually come late. Okay. So if you talk about best marker of acute infection is IgM core antibody. E antibody is a marker of non-infection. IgG core antibody is a marker of chronic infection, and the surface antibody it is seen in vaccinated person. Okay. So in fact, rather the only finding that we get in a vaccinated person is surface antibody, right. Hence in this question the best marker is core antibody. So you can note down few more extra points. Write down. Number 1, best epidemiological marker is surface antigen. Number 2, first to appear surface antigen. Next, marker of infectivity E antigen. Next, marker of non-infectivity E antibody. Now let us talk about window period. Look, surface antigen disappeared here and surface antibody appeared. This time gap is known as window period. So window period is the time gap between disappearance of surface antigen and appearance of surface antibody. Okay. I hope you got many more extra points about serology. Question number 6, it is a related question to question 5. A nurse has been found to be positive for both surface antigen E antigen, suffering from. The answer is acute infectious hepatitis B. Okay. Let's see, other option. E infection, there is nothing to suggest about E infection. There is E antigen, hepatitis B antigen, it is not hepatitis E virus antigen. Do not get confused with hepatitis B with E antigen. So this cannot be that option. In chronic infection, usually E antigen does not persist. Okay. Of course, they have not mentioned about core antibody. Still, E antigen is usually not there. It is more likely to be in acute infection. Past history of hepatitis infection is suggested by just IgG core antibody. The best answer of this is acute infectious hepatitis B. So if you see the previous slide, so it is somewhere here. Okay. Hence A is the best answer. Question number 7. A 70-year-old female suffered from influenza and she developed pneumonia, died, most likely is Staph aureus. Staph aureus is although it is usually a infection, it causes infection pneumonia in children, but after influenza epidemic, Staph pneumonias are very common. In fact, influenza and Staph, they are the deadly combination. Mortality is very, very high. Now a few extra point about Staphylococcus pneumonia. As I told you, although more common in children as compared to adults, but our patient is an adult. Now in Staph pneumonia, then you get multiple cysts, so called pneumatocyst. That is why they can rupture and they can lead to pneumothorax. Now something very interesting, we have for Staphylococcus, we have drug like linezolid, amoxiclavulinic acid, amikacin, but you will be, I hope you are well aware, these drugs are now also used as a newer anti-tubercular drug. But at the same time, one more information which is not known to most of students, rifampicin is a very good anti-staphylococcal agent also. So what we are noticing, the anti-staphylococcal agents, they are effective against tuberculosis, and this rifampicin, which is the anti-tubercular drug, is very effective against staphylococcus infection also. And when we are talking about newer drugs of tuberculosis, the discussion is always incomplete if I do not talk about the latest anti-tubercular drug is bedaquiline. And bedaquiline, I can write again. This question will surely come to you in any of the forthcoming exam, bedaquiline. But a big drawback of this drug is it can lead to prolonged QT interval. Okay. So you got a lot of new information about other tuberculosis drug as well as staphylococcus. Now, in addition to that, some more information for you. We have a UG test series for the undergraduates. We have a PG test series for the intern and post intern, and I am very happy to tell you we are the only one. Of course, we do give you explanatory answer hard copy, but we also do online video explanation. We are the only one who give you this extra advantage. We also have a champion live test series where you go to computer lab to write so that you have actual feel of the exam. We also have a MLE step 2, you can see detail, you must see this lecture, okay, must see, whether you are writing any exam, you must see this lecture. And we are conducting lab 2 also, you can see the detail, the book series, last minute revision points. In the last previous exam, 143 question out of 300 question came from our last minute revision point. You can see I have recorded many lectures in they are in YouTube. You can see my lecture in YouTube channel, and if you want to get directly connected with me, you can send your name, which year you are, college, city, and email at my personal WhatsApp. I will be sending you lot of updates and lot of LMRPs. Once I finish AIIMS series, I will be also doing for PGI and JIPMER test discussion also. Simplified is a mini Harrison for undergraduates, and this is the question bank based on 19th edition. These are the extra things that we provide to all of you, and take advantage of all these things. And thank you very much for watching this video. Stay tuned.